Hi, everybody. I'm Charisse Santos, and I'm a Patient Services Coordinator with the ALS Association Greater New York Chapter. So glad to have you here. I wanted to remind everybody that during the presentation and after, if you want to post any questions, there's a Q&A tab at the bottom. So please feel free to do that. I'd like to introduce Katie Dimarco, a palliative APN and clinical supervisor at Hackensack University's Medical Center's Pain and Palliative Medicine Institute. And she is also part of the Hackensack ALS Clinic. So Katie, nice to have you.
Thank you so much. Thanks for having me. I really appreciate it. And I will go ahead and share my screen and we'll get started. So like Charisse mentioned, my name's Katie Dimarco. I'm a nurse practitioner at Hackensack University Medical Center, and I've been really fortunate to become embedded in the Hackensack University Medical Center ALS Clinic, where I work with Charisse and the interprofessional team. And I'm glad to be here to talk about palliative care. I have no formal or informal disclosures. Personally, I'm a mom, I'm a wife, I'm a clinician, I'm a daughter. And so I join you here with wearing different hats, as you all do as well. So together, I'm hopeful that we can learn what is palliative care, highlight how personhood and traditional and untraditional medicines can really come together, that clinical personhood concept, and review how palliative care can support people who have the diagnosis of ALS, their loved ones, their caregivers, and even unpack what does it look like to have that extra layer of support. I do encourage you to ask any questions, whether they're thematic or very specific. I am happy to answer questions during this session or even afterwards. So what is palliative care? You know, when we go in to meet patients, and it's my first patient appointment, I introduce myself, obviously, but I'll even mention and ask, are you familiar with palliative care? And it is so common and almost expected that people say, no, we're not quite sure. And so the foundation of what palliative care is really important. So then we can work really in tandem together. So palliative care cares for people who happen to have serious illness, whether it's the diagnosis of ALS or say consideration for when people have cancer or heart failure or other serious illnesses. We zone in on 4 particular concepts that could be helpful for people who are living with illness. Specifically, it's symptom management help, advanced care planning help, or talking about personalized thoughts and medical preferences, understanding what quality of life means to the person who is living with serious illness, as well as including their caregiver family support circle, and that's more so their chosen family and or their biologic family. Those are the 4 main concepts that palliative care offers and we do together. Now here you'll see that symptom management is more than just the physical concept. It includes emotional symptom management and even spiritual symptom management. And that's where, say, the art and the science comes together on what we may talk about or what we may support. I think sometimes word collages can be fun, as you may just naturally pick out some words that resonate with you. But this is a palliative care word collage, and some of the concepts that resonate with me is quality, families, get. Some of the concepts that really, stick out to me, I love the just that thought process on the bottom right-hand corner of your screen, just resonating with kind of a wonderment. Other words may stick out to you within this word collage. So who implements or participates in palliative care? I think it's extremely thoughtful that palliative care is an interprofessional team that can help support people with ALS and their loved ones and their caregivers. And you'll see here that we work with clinical chaplains, social workers, psychologists, nurses, nurse practitioners like myself, physicians, and even other healthcare professionals. And that ... really means that we work with pharmacists, we work with speech therapists, we work with a large group, but all of these clinicians can actually specialize in palliative care in specific. And so it's very much an interactive specialty that works with you. Ultimately, palliative care is there to companion you and your loved ones when you're having challenging days or when you're having joyful moments and days. And our role in companionship is to be present, to validate what you're going through, and if and when helpful, identify resources, interventions, care plans that are personalized. But sometimes, ultimately, people want an active listener, and with permission, they may want more. So flipping around this, word collage with palliative care, what I see now is that palliative care is about people. And that's what makes me smile about working with patients and working in the ALS clinic at Hackensack, is that the people that I work with, the patients, the caregivers, the loved ones, and the other clinicians, it makes it a very special place. And so what is clinical personhood, and why might I have even identified, that clinical personhood is in my title and important to talk about? And the basics is that it is extremely, I think, thoughtful, meaningful, and important to know people and to understand what is that person made up of? What's their story? What's their experiences? And connecting their prior experiences, their present experience, to the tools and the resources that the healthcare system has. And so literally just connecting these two things, upholding personhood and upholding clinical resources together, that really speaks to clinical personhood and what palliative care can support you all and others with. One of the fundamental things that I think about when I think about clinical personhood is really identifying not what matters to me, Katie, that doesn't really matter so much. What matters to you? What matters to you at point of diagnosis? What matters to you when the illness changes? What matters to you when you may be in a transition and dying? And so what matters may evolve, just like life and our experiences with illness evolve. For the remainder of our discussion, we're going to be going over 8 specific layers that palliative care can review with you as a patient and family member. But I want to show you the breadth and the foundation of where palliative care and you can really collaborate regarding your care. And so part of palliative care and acknowledging that we live in this New Jersey, New York City region, we actually do have pretty great access to palliative care compared to other areas of the country. In this New Jersey and New York City region, we do have ambulatory palliative care, such as the clinic that I work in, as well as telehealth, which there has been some recent state-to-state modifications. But in New Jersey, we still have New Jersey-based telehealth, and other states still have their state-based telehealth opportunities. There are a lot of acute hospitals locally and regionally that offer acute palliative care services. And we even have the ability in some areas to have home palliative care when travel gets more burdensome or it's just too much or affects other medical appointments. And so in this area, we are able to welcome people into the palliative care field. So thinking about access, oftentimes, clinicians, neurologists will ask me, well, Katie, when's the right time to introduce palliative care? It's generally recommended to introduce palliative care at any point of serious illness, but upon diagnosis is a preemptive thought as it's a time to get to know each other. And so this blue continuum is showing you that neurologic care, which can be so important for medical resources, safety, understanding what next steps might be available, as well as palliative care working alongside neurology and your other care team members. And there's a give and take of when you may need more medical neurologic care or when you might need more communication support or palliative care assessments and resources. And of course, we acknowledge whether you have ALS or not, there comes a time when we enter our end of life and we go through that dying process. And so we'll talk more later about what options and resources are available. So the foundation of palliative care is you. You are the focus as the person who has the appointment, and experiencing and learning what your story is and who you are is really a time of partnership. We learn more about your life experiences, how you feel your life has evolved, your life stage, where you are with your relationships, and how do you navigate your healthcare, or does someone do that on behalf of you? We learn about what's important as far as how you identify yourself, whether it's a professional or a veteran, how dependent or independent are you? And we really just gain more information about you so we can possibly support and anticipate what you may need then and or in the future. The social aspects of care, and I mentioned this before, even include your chosen family, your biologic family, your support system. However you want to define this group of people, we look to understand, say, that structure or the family tree, the function of how you all work together. What are your strengths as you work together? And what seems challenging as you navigate this new illness and these new stressors? It's helpful for safety reasons and other social reasons to understand your living arrangements. What relationships do you feel particularly connected to and with? And I think about yesterday's presentation about intimacy, that connectedness, and or how do we express ourselves within our relationships, whether it's intimacy, sexuality, things of that nature. And what kind of resources or financial burdens are you going through? Again, we're peeling off the layers of getting to know each other. And this social information could just naturally come out during one appointment or could slowly evolve in information sharing and gathering as we have further interactions together. The cultural aspects of care, and this is kind of a colorful infographic that is really highlighting that we have layers to our being. We are more than just our physical appearance or our particular race or how we might identify ourselves. And that's what makes humans and working with people interesting and inspiring. So all of these things come together as we work together and get to know each other. It's really the foundation of your personhood. For communication reasons, it is so helpful to know what language is preferred, what devices or concepts are not to be shared. There have been so many times where during appointments or even after the appointments, I'll hear someone, contact me either in a whisper in my ear or even through an email, "Don't say," and it could be any kind of word that the family or the patient's not comfortable with, but to understand that cultural and communication piece only benefits my knowledge to then benefit you all and make sure that our appointments are safe places. It's also a time to explore, tell me more. Tell me more why I shouldn't use that word. We'll respect it, but help me understand your perspective and meaning. Also within culture, there are practices and values, even rituals, that might be important when we're diagnosed with a serious illness, when we're preparing for dying, while we're dying, at the time of death and post-death. And those are concepts that are to be honored and upheld and really sacred if they're meaningful for you. So peeling off the layers again, a lot of people feel that spirituality, religion, and even existential concepts are meaningful to them. A lot of people also tell me, no, it's not important. I don't believe, and they explain what their belief system is not, as well as what their belief system is. Again, this is exploration on how to partner and get to know each other. So then there are no assumptions, and we can work closely together about honoring your beliefs, values, and traditions. So whether you align with a non-belief, which is a belief, being a spiritual being, or identifying with an organized religion, or even just feeling human and wondering, how do I relate to these life experiences, to these illness experience? What is the meaning of all this? This is part of where we can spiritually go in asking these big questions. And to be clear, palliative care or I don't necessarily have all the questions and answers, but we often do have that reflective space of, I wonder, let's talk it out. Let's talk about what it's like to feel free in one regard and yet responsible in another. Let's talk about what you might be feeling as you're thinking, oh, I'm being more connected to my life, to my community in this way, and yet I'm feeling isolated in a different way. Contradictory feelings and experiences can happen at the same time. It's called middle knowledge, where 2 feet or 2 parts of your experience and thought process are actually feeling 2 different things, and that can feel confusing and sometimes it's hard to talk about or put words to the inner feelings of what you're experiencing. With this in mind, there are additional layers of how are we psychologically? What is our wellness like? What are our lifestyle changes and how are we coping with that? Are we able to utilize, prior strengths of coping, or are we feeling as if those coping strategies from prior are just not serving you and you're looking for more or different strategies? Stress level, memory, recall, the feelings of sadness or worry are penetrating to people who have a serious illness, to those who are observing, their loved one with ALS change over time. This happens in a human way. It's not necessarily a judgment or a time to label. It's a time to validate and acknowledge that it's a human reaction to go through different periods of wellness, different intensities of sorrow. It's just different for everyone. For physical aspects of care, and palliative care is particularly skilled in symptom management, whether we prescribed medicines for symptoms or conduct interventions, or even think about integrative modalities like Reiki, massage, and give referrals for other concepts. My patients that I've worked with over the years who have ALS have 5 specific themes of symptom burdens that they've shared with me. There's a combination of, say, weakness and fatigue. Sometimes I often hear the word of heaviness in their body. There's an expression of pain, more so spasms or spasticity. There's a symptom of, say, that secretions or even drooling that can occur. As well as things change, there could be a sensation of shortness of breath, the dyspnea, not feeling as if they're catching enough of their air. And with this, I'd like to tag on that, you know, the saying like the chicken or the egg, which one comes first? Sometimes, if we think back to the psychological slide from prior, sometimes we get worried, anxious, and even have a panic attack. It's natural for us to have that sensation of shortness of breath. And so anxiety and that sensation of worry can cause that symptom of shortness of breath at the same time. It's an involuntary reaction. And so to acknowledge, and wonder, is your shortness of breath from anxiety and panic attack-like situations? Or is your shortness of breath because your lungs are changing? And sometimes when your lungs are changing, you do feel short of breath, and then that makes you anxious. So palliative care can really sort through what might be the core symptom. How do we treat the core or the root of the symptom? And then also, will then your second symptom improve? And so we go down this assessment and reassessment discussion to sort out the weeds, really drill down what your body may be feeling and what you're experiencing. The additional symptom that people often want to talk about is sleep. Difficulty falling asleep or staying asleep, so the insomnia concept, as well as people talk about their dreams, whether they're processing or coping through their dreams, or they're just a very vivid dreamer in history, so they are today. Or sometimes medications can cause an altered sleep experience or even dreams. So I offer that as something to unpack and discuss with your clinical team or with even palliative care, a psychotherapist or counselor, as dreams can really be impactful. As you wake up and you feel, wow, that was a really scary dream. And it may or may not affect the rest of your day or how you start your day. But let's personalize further. I wonder, and maybe in the group chat, maybe I wonder what your symptom burdens are or what symptoms you're concerned about. And we could go over how best to help those. Today, we're not going to necessarily talk about the medicines I would prescribe for these symptoms, but that of course is something that we can talk about through the chat or at an offline time. But just know there are medications to support these symptoms that are not contraindicated or causing any problems with your ALS medicines if you choose to take them. This next area of, say, a palliative care layer that can be discussed and hopefully is a supportive concept is your ALS care plan and your neurologic medicines. Are you leaning towards participating with research, or do you and your doctor want to work with Radicava or whatever might be recommended? There's also discussion sometimes earlier on, or maybe just within yourself, as far as what supplementary nutrition or even medical nutrition and feeding tube might you value or think about as the illness progresses? As well as concepts of, if I have breathing changes, what breathing apparatuses or breathing machines, whether it's a ventilator or having a tracheostomy, might be something I'll want to talk about, or something I may say no thank you to, or wishing to have that type of intervention and lung sustaining help. The concept of CPR and resuscitation is all part of what could be really helpful to understand your medical preferences, so we can honor what the conversation needs to be, as well as honor your wishes. With that in mind, sometimes there are unplanned emergencies, whether they're car accidents and other traumas, or a medical event that's not expected. Having a healthcare representative through a proxy directive really tells the nurses and the doctors and the care team, particularly say for your local hospital where you receive your care, who to call to make your medical decisions if you can't speak for yourself. And so I'm going beyond an emergency contact. Identifying a healthcare representative is really someone who can speak to your wishes, honor your preferences, and be the information sharer with your care team, say in the emergency room or during a hospital admission. They can also be your advocate and support when you're in, say, the clinic and in an appointment. Another additional document that can be really helpful when you are considering writing down what you would like to have, say, yes, in a time of needing a ventilator and a tracheostomy, I would like to have that. A living will is that story of your medical preferences. And so that also can be a very helpful document if you feel clear about your wishes. And then, of course, you're going to be making decisions about end of life care. And that is likely different than when you weren't diagnosed with ALS, and maybe end of life care and that type of discussion maybe wasn't on your radar. And a lot of things may be popping up in your mind as we go over this bulleted list. Our role in palliative care, again, is to companion you, is to identify what kind of discussion is helpful for you to sort out your thought processes, to sort out what questions. Sometimes people even say, I don't know what to ask. And so we could go over some prompts about what could be helpful to think about, what could be helpful to talk about. And we have check-ins of, is this okay? Is this now a time to stop? But we are very much here to companion you regardless of what decisions you make. But we are, an information resource about the what ifs. I mentioned a healthcare proxy as well as a living will. And the 5 wishes to your right ends up being a thoughtful combination of a proxy directive as well as a living will. And it has 5 main prompts, hence the 5 wishes. I find a lot of people like this type of document as it's legal and valid in many, many states in our country, as well as it gives you prompts to think about within what is important to me, what kind of medical care or treatment would I want if I was in an illness crisis or even in a dying stage? What is important physically, and how would I want people to treat me? What might I want my environment to feel and look like? If you benefit from prompts and or like details, I do recommend that you look at the 5 wishes, and we can absolutely get you a copy. To the left is a more basic instruction directive that is more like a cut and paste X here kind of concept. So I just wanted to show you a variation, but your community, whether it's a religious organization, your healthcare system that you work with, there are many different types of proxy and instruction or living will directives. So just know that there's more than just these two options for you. Okay. So we're talking about care decisions, and when people are at that life-limiting stage, New Jersey and other states have what's called a POLST form. It is practitioner orders for life-sustaining treatment, and this green form is the New Jersey form, but for example, the New York state has a MOLST and it's bright hot pink. They're the same concepts. So each state has its own order form. And basically how this is helpful is if a patient or their healthcare representative decide that it's important to put their wishes into orders, this is the form to really consider. This form allows continuity. And this form, because it's orders, is honored by everyone in the state. So think about that. Home care nurses and team members follow these orders. Hospital emergency rooms, EMS, hospitals, people that are, receiving you in their clinics or their practices for your medical appointments. So if there's something particularly that is very important that we, the care team, absolutely follow, this is a highly recommended form, as you can continue these orders at every single point of contact. In addition, this POLST form can be voided and updated at any time. It is important that you complete this POLST form with a licensed physician, APN, which is advanced practice nurse, or a PA, which is a physician assistant, because those are the clinicians that are going to guide how to translate your wishes into orders, and you complete the form together. So I highly recommend that this is a thoughtful telehealth or appointment or completed with a clinician that you trust. Palliative care recognizes and hopes that you have life and illness and live as long as possible. We also recognize that people, regardless of diagnosis, will near the end of their life and will start to have that more active dying time at some point. When we care for people that are starting to transition, some concepts that can be really helpful or thoughtful is legacy planning. When I think about legacy planning and some of the prompts, if it doesn't naturally come up, is legacy planning from a concept of sharing your story with the generations of people that are part of your support group and community. I think about, if you're a grandfather, what do you want your grandchildren to know? Is there an opportunity to write a letter to someone that would be graduating or having a life milestone in the future? I think about those connections on how can palliative care or other people in your care team uphold your connectedness even while you're dying or after your death. So there are legacy projects and discussions that can be unpacked at any time. And then, of course, there's the estate and financial concept, which I think is more readily discussed with families and or lawyers, but they all go hand in hand on people becoming, say, their readiness or completing their tasks, what they may feel is important. Palliative care can also help support and educate people about the dying process. Sometimes people feel embarrassed or worried to ask questions, and I am all about transparency. If you ask a question and it seems sensitive in nature, I'll even ask, is it helpful that I answer that question? Sometimes people want to ask a question, but it may be up to that moment if they're ready to hear the answer. Sometimes people want to ask questions about dying in different forums, whether it's a telehealth, an email, or a whisper literally in my ear. But it can relieve some pressure. It can relieve some stress when your questions are answered. And of course, I honor if that's helpful for you. For end-of-life care, hospice services are often the most coordinated service that is covered by insurance or supported in another way. And so coordinated end-of-life care can be really helpful to make sure that you have all the medical and safety resources during this sensitive time. And then medical donations, say of tissues and organs, that's sometimes not talked about, but there may be an opportunity to donate to research and to other areas to have that altruism of continuous learning and how your body may benefit others. Here I have a comparison of how palliative care and hospice may be similar and yet different. And focusing in on hospice services, it's really meant to be part of end-of-life care. They're the specialists in end-of-life care, and you can continue that care when you're in need of, say, specialized symptom management during the dying time, really focusing in on that emotional and spiritual preparation personally and within your family. It's commonly paid for by insurances as well as Medicare, and it offers bereavement, which are supportive counseling services to your loved ones when you pass. So all in all, what I'd like you to consider is palliative care when you think it might be right for you. And if you're not quite clear when it might be right for you, then consider upon your diagnosis or even after this presentation. Lean in on your care team and share your story and experience. And let's consider how to personalize your medical care, how to share those medical preferences with your care team. Let's focus on what matters now and what might matter to you in the near future. And even if you're open or desiring to, how to help support you in your future. That narrative and that support can always change as you change. And overall, your care team and palliative care, we're going to be here to support you. And I hope you feel that from this presentation. So again, my name's Katie Dimarco. I am so thankful and honored to be invited to this conference and this forum with you. I'm hopeful this was informative and helpful. My email address is here. My office number is here. Please reach out through the Q&A if you have any questions now or at another time, but just want to say thank you very much for having me.
Thank you, Katie.
Thank you.
There is a question regarding the slide that you had about the symptoms. And, you know, you said you weren't going to go over medications and stuff, that slide.
Okay.
The question is, in my experience, anxiety and insomnia are clearly related. For example, since I can't do anything like turn on the TV or read a book in the middle of the night, it's a great time to worry. So
yeah, that resonates with what I hear from others. And it's one of those, say, more still times at night that we don't have positive distractions or routines. And so we might sit with that worry, anxiety. Even sometimes people will describe it as like flutters in their chest, in their mind, in their heart, where they just feel, something starting to race or act up. And so when we're in a situation of that cluster symptom, anxiety and insomnia, sometimes medications prior to bedtime can be helpful. Sometimes it comes down to if we don't want to use medicines, because sometimes people are like, don't give me another pill, like I eat enough of them. Sometimes it's talking out what kind of sleep routine and rituals might be helpful. And I'm not going to go over sleep hygiene. I think a lot of people may or may not believe in that. I really consider it more of a ritual of how to ease that stress or anxiety, or how to validate that it's happening, and then how to ease into that sleep. I know that oftentimes people will use technology aids like TV or reading on their iPhone and things of that nature. That light interaction with your eyes to your brain actually overstimulates people. This is kind of a funny thing, but it's a sleep psychologist once told me during COVID, when a lot of people were having anxiety and insomnia challenges, that she highly recommends that you get the most boring piece of material, physical paper, and you read it. And her example was a dustbuster pamphlet or a microwavable pamphlet, and that's not always realistic. But I smile in the simplicity of that. So oftentimes there can be a small modification or progressive modifications to ease the anxiety and the symptom burden that you're speaking of.
Great, thank you. And I know you had a slide between palliative and hospice, but the question is, what's the main difference between palliative and hospice?
Great thought. Palliative care, you can think of it as all of that support symptom management, regardless of what kind of medical decisions you make. So, for example, if you choose to be involved in research, if you choose to have Radicava or any of those medicines, if you choose to have the intervention of, say, a tracheostomy and a ventilator, you can have palliative care no matter what. There is no limitation on how long you can have palliative care for. Hospice, in contrast, is when someone is identified to likely have 6 months or less. That is a specific estimated time frame of when you're invited and thinking about hospice services. So that time is very specific when you think about hospice. 6 months or less is that caveat. And that's often medically referred to as a terminal time, that dying time. Palliative care, anytime.
Great, thanks. It brings me to another question. And the question was, can I just ask my doctor for palliative care evaluation?
Good thought. I don't know where you're located, but generally, yes. I would suggest that if this is a clinic or ambulatory concept, you likely don't need to seek permission. You likely can make an appointment, as it's a very valid appointment and interaction to have. But I think shared information and transparency is very helpful, so then your doctor and palliative care can work together, and that just optimizes your care so much more. If you're in the hospital, most hospital settings do seek physician approval because there's always an attending physician in charge. So if you're in the hospital with an active admission, that's when a physician may, want to hear, oh, can I meet with palliative care? And they'll put in the referral. But depending upon your location and which healthcare system you work in, it has slight nuances. But if you're interested in palliative care, then I recommend you get an appointment.
Okay, all right, great, thanks. That was and then as you were talking, another question came in through the Q&A that pretty much you just answered.
Okay.
But the person's in New York City, so I don't know if you can answer that. Is it difficult to get in New York City? So
Good question. I'm familiar with palliative care teams in New York City. I'll say that New York City is particularly one of the most locations that have great palliative care services. And whether it's New York Press, Columbia, Northwell, Mount Sinai, they all have, and others, but they all have ambulatory palliative care clinics that likely might match with your location. But yes, New York City does have great clinic palliative resources.
Great, thank you.
Sometimes part of the challenge is how do you find them? If it's not clear on their website, then that could be a connection point that the ALS Society and I help you with.
Oh, okay, great. And I mean, I guess you're the person's neurologist, if it's New York City, can help as well.
Absolutely, they could help navigate that. And a lot of neurologic clinics and ALS clinics have a connection to palliative care. It just might be different from system to system. So.
Okay, thank you. And then I know you said, the question is, can you get palliative care at home? Now, I know that answers, but.
Yeah. You can, but I would say that's the most, that's the hardest one to find in all regions. And so in the Bergen County area, we're fortunate that the Valley Health System has a home palliative care program. Down in Central and South Jersey, Hackensack Meridian has a home palliative care program. New York City, they do have some home palliative care programs, but it's a little bit Swiss cheese, meaning there are holes and gaps of care for the home setting. And so that's where the telehealth might be a good compromise or bridge to get some help if home palliative care is not available in your location.
Great, thanks, Katie. I don't see any more questions coming in, and if there are any in the Whova later, then we can get together for those.
Okay.
But I really appreciate it. Very insightful, and really glad that you could come today.
Thank you. It's been a privilege.
Okay, great. I want to remind everybody that the next session is a caregiver's journey. So if you could please join us for that, the next session, and we will see you there. Thank you, everybody.